Well, good afternoon, everybody. We're going to get started. Welcome to the Occupational Hygiene Association of Ontario's and the Canadian Aerosol Transmission Coalition's joint presentation of respiratory protection in the workplace. My name is Anne-Marie Landis-Groom. I'm the immediate past president of OHAO, and I will be one of your two moderators today. So the pandemic has brought personal protective equipment, especially mask use, to the public eye. Effective transmission reduction of SARS-CoV-2 or other airborne hazards requires a consistent respiratory protection program, or RPP, plus ongoing attention to matching the device choice to function and ensuring the correct fit. These are all daunting new concepts for many workplaces where they have not previously been required or needed. Professional occupational hygienists and members of the Canadian Aerosol Transmission Coalition would like to help workers and workplaces gain practical understanding of respiratory protection programs, when they are needed, how to get started, and where one can go for more information and assistance. This session will be focused on the why, what, and how of respiratory protection programs. You'll have an opportunity to ask questions from our panel at the end of the session, so please fill your questions in the question and answer box. And join us next week, June 15th, same time, same place, for the second part, which will focus on more the practical aspects of choosing respirators and getting fit tested. Now, if you haven't heard of the Occupational Hygiene Association before, we're an association that represents professionally accredited occupational hygienists and some other people who are also interested in the field. And as a group of experts in workplace exposure issues, we have a very high-level vision of living in a world free of occupational disease. Part of our mission is to advance the profession of occupational hygiene by providing public education information such as today. Please feel free to visit our website or follow us on LinkedIn. And now I would like to introduce my fellow co-moderator, Kevin Hedges.
Thanks so much, Anne-Marie, and hello, everybody. And thanks so much for joining this really important webinar. So this is a three-part series. This is number 2 of a three-part series. So this is my Mask Smart 2, and this follows Mask Smart 1, protect yourself and others today and tomorrow. And then on the 22nd of June, we have Mask Smart 3, which really goes into the meat of what's in a respiratory protection program. So I'm representing the Canadian Aerosol Transmission Coalition, and I'm very honoured actually to be representing them. I'm a member, so Alec Farquhar, who will talk in a minute, is the coordinator, and the chair is Dr. Stefan Bilodeau, who's actually a professional engineer and he has expertise in ventilation engineering. We also have doctors, medical doctors, and microbiologists. And we truly are interdisciplinary. So we kind of bring that flavor along with OHAO. And we're really glad that Anne-Marie was able to, get OHAO to be a partner in the coalition as well. So that's basically it from me. I'm also the former president of Workplace Health Without Borders International, and WHWB is also a coalition member as well. Back to you, Anne-Marie.
Super, thanks, Kevin. So before we get into the meat of our presentation today, I would like to introduce OHAO's current president, Joanna, and the Canadian Aerosol Transmission Coalition's coordinator, Alec Farquhar, for their opening remarks. Welcome, Joanna and Alec.
Thanks very much, Anne-Marie. Alec, if I'll go first, just to echo some of the sentiments, both from Anne-Marie and Kevin. OHAO is an organization that is always looking to expand its relationships with like-minded organizations and build meaningful partnerships. And as Kevin mentioned, when the opportunity came up for OHAO and the coalition to partner together and for OHAO to lend the industrial hygiene voice to the conversation, it was a no-brainer at the time. And Anne-Marie and Paul from our organization have been contributing to those discussions. And I'd just like to say thank you to everyone who has worked to put together today's session. Such a meaningful topic, such a timely topic, and I think everyone on the call here will find it purposeful for their needs. And I hope everyone can join us again next week for part 2, as was introduced, to continue on that conversation. So again, thank you to everyone who's been involved in putting this together.
Thank you so much, Joanna. Then what I will now do is introduce our first speaker.
Hold on, Kevin. We have Alec giving opening
Alec.
remarks
Yes,
from the
okay.
coalition.
I jumped in. Sorry, Alec.
Thanks, Kevin, and Anne-Marie. Thank you, Joanna. I'm Alec Farquhar. I'm the coordinator of the Canadian Aerosol Transmission Coalition. I'm really, really pleased to be part of this very important event today. Just to provide a little bit of background on the coalition. When COVID came along, there were a number of us, I'll include myself. I'm a lawyer and was at the Ontario Ministry of Labour following SARS-1, and I was responsible for a big part of implementing the Archie Campbell recommendations. So I knew the issues very, very well. And I was one of many people who were concerned about some gaps, some serious gaps in the response to COVID, especially the seeming refusal or denial of the potential for aerosol transmission. So a lot of us, or groups we were involved in, like Workplace Health Without Borders, got involved soon after COVID arrived, and we're working on our own. Then in the fall of 2020, we came together into what became the Canadian Aerosol Transmission Coalition. And we really stand for a couple of key principles that I think are important in general for responding to any public health emergency or urgent situation such as this. First of all, we are science-based, and we try to bring that science to the front line and really represent the science the best we can and keep checking and making sure that we're on track and that new developments and new research are fully taken into account. Secondly, we're multidisciplinary. The fact that this is co-sponsored with OHAO is really important because it shows the vital role for occupational hygienists in the response to a pandemic. And that role hasn't always been fully acknowledged by those in authority. It tends to have been run by physicians and really directed with that kind of perspective, which is, of course, valuable, but also needs to be accompanied by a multidisciplinary approach. So we have hygienists very prominently in our coalition, engineers, especially ventilation engineers, people who are experts, in fact, leading experts on personal protective equipment and respiratory protection programs, which we're looking at today, occupational medicine, infectious disease, legal and regulatory, and more. So we're trying to really represent that multidisciplinary approach. We've tried to make links based on that, where we felt we could have the most impact. We've reached out to the Ontario Science Table. We've reached out to the Public Health Agency of Canada, sometimes with some engagement and sometimes perhaps not. We've done a lot of media work. If you've seen people in the media advocating for protection against aerosol transmission, as likely as not, it's either one of us in the coalition or one of our coalition partners. And I'll put the link for the coalition in the chat so you can check the partners. I won't list them all now. We feel we've had a real impact after this pretty bad two and a half year experience now. Having said that, there's a long way to go. And the vital message I think we've been sending most strongly lately is the need for a layered approach to prevention and protection, in which hopefully the combination of ventilation, of air filtration, of good quality respiratory protection programs, cohorting, administrative measures, distancing, et cetera, that combination will keep working effectively to protect workers and the public. So at that, I'll put the link in the chat, and I'm looking forward to sitting back and learning a lot about respiratory protection programs along with everyone else. Thank you.
Thanks, Alec. I'll read the script next time. Just before we move on, I just want to acknowledge the Indigenous here and give it an Indigenous territorial acknowledgement. It's really important that we just acknowledge Indigenous, and I guess we're kind of far flung. We're kind of like this. We're the Canadian Aerosol Transmission Coalition, so there's not one particular Indigenous territory, but I just want to say that. I also want to just mention that the Canadian Aerosol Transmission Coalition, it's not an exclusive body. We're inclusive. So we meet on Thursday nights, and anybody's welcome to come along and listen to what we have to say. So I just wanted to add that as well. Okay, the first or the second item here is why masks matter. Why masks still matter for COVID and beyond. And it gives me a great pleasure to introduce everyone to Dr. Kashif Pirzada, who's the co-founder and co-chair of Masks for Canada. Dr. Pirzada is an emergency physician from Toronto. He's affiliated with University of Toronto and McMaster. And I just thought what I want to also say is I was kind of doing a bit of research on Dr. Pirzada and see that he was given the Arbor Award. He's the Arbor Award recipient in 2019. And I think this just kind of sums up a bit about Dr. Pirzada. So he mentored pre-med students from unrepresented backgrounds through the Faculty of Medicine's Community Support Program. He's very charitable. You see him interviewed lots in the media. As I said, he's the co-chair for Masks for Canada, and he's been very generous with his time, obviously now, and also through the Occupational Health Clinics for Ontario Workers. He's actually presented a couple of times, and it's no problem for Kashif just to come on and present. So he's very passionate about this topic, and I just want to thank you, Dr. Pirzada, for speaking to us. Over to you.
Thank you so much, Kevin, for that really kind introduction. I actually have a lot of those students working with me this summer, trying to uncover a lot of issues in the pandemic, including, and I basically tasked a bunch of them to figure out long COVID. So hopefully we'll have this problem figured out by the end of the summer. So I'm just going to share my slides. So can you guys see my screen? Okay, I'm assuming yes. I'm going to go over quickly why masks still matter for COVID and beyond. So a little bit about myself. As Kevin mentioned, I'm an emergency physician. I have academic ties to McMaster and U of T. Helped found Masks for Canada, which is a group that tries to limit the morbidity and mortality from COVID-19 as much as possible, with the initial mask mandates and advocating for to prevent airborne spread of the virus. I also helped with a group called the Critical Drugs Coalition to try to alleviate drug shortages, which hopefully have improved a lot since the pandemic started by simplifying supply chains. And you can find me on Twitter, where I'm quite active, and you'll see a lot of opinionated opinions from me on there. Basically, this is very current. Like, why is masking still relevant? Everyone around us, many people around us seem to think that the pandemic's over. We just had an uptick in wastewater signaling in Ontario. And then, you see when you look at wastewater surveillance, this is almost a cyclical, every 3 months type of problem that we're dealing with now. So this pandemic is not over. It's not close to being over, and we're going to be dealing with another wave within a few weeks. An interesting paper just came out yesterday, actually, showing that immune responses to Omicron are not that great, and which could explain why so many people are being reinfected even after getting Omicron in the last few months, including our own Prime Minister in Canada. What's disturbing is you look at countries in Europe who are just starting a wave with the newer BA4 and BA5 variants. You have Portugal with one of the highest vaccination rates in the world, one of the highest third dose rates in the world, and you're seeing a spike in mortality. So this is very disturbing. Everyone really needs to be made aware of this, because the pattern that the Europeans are seeing now is going to be replicated here shortly. Hopefully, schools being released soon. Hopefully, summer weather will mitigate some of that. That's the hope. but by no means is the pandemic over. So I'm going to discuss, simple measures that clinicians can take in a workplace. Despite the dropping of mandates, you can still make a safe space for your patients and for yourself with a few simple measures that, I've implemented in chronic pain clinics that I work at along with my emergency practice. Firstly, masks, despite the dropping of mandates, are an essential line of defense. There are serious limits to one-way masking in which the clinician is wearing a mask and the patient is not, which is a scenario we might run into. But with a properly fit tested N95, you still will have some significant protection. But unfortunately, the patients who are unmasked will not be protected from each other. So that's one step. There are some complications in Ontario because their mask mandates are being upheld in every single hospital, but through some, I guess you can call it inconsistency in the guidelines, they cannot be enforced in clinics. So medical clinics which have already been, which haven't really been upgraded in a systematic way, their ventilation will have to see patients unmasked, and there's limited ways in which they cannot see them, according to guidelines from the College of Physicians, unless this is clarified. So some strategies that can be used is that, strongly encourage mask wearing in the clinic. Try to schedule separately your more vulnerable patients, the elderly, young children, cancer patients. Try to make a separate time for those patients who want to forego masking. Perhaps use telemedicine more unless in-person physical examination and procedures are absolutely required. And then upgrade your clinic ventilation to control any potential super spreading events. I wrote a legal paper once with some colleagues. The Human Rights Code does not include the right to not wearing a mask as a protected grounds. As far as I know, I'm not a lawyer, but really what the gist of our Human Rights Code and our legislation is that accommodations need to be made, as reasonable accommodations to personal preferences, and scheduling separately or going to telemedicine as a default sound like reasonable accommodations that can be made, and I hope would stand up in any kind of college proceeding or any kind of court proceeding. Obviously, the quality of the mask matters. Really, the age of cloth masks really needs to be, consigned. I'm puzzled why some people are still wearing them, but really tight fitting or well fitting, KN95s, or at the best end, the N95 fit tested respirators really need to be worn in the clinic. And your next step beyond masking is getting more fresh air and filtration. So measuring your CO2 levels. This is an Aranet CO2 monitor. The air quality is not the greatest in my office right now, which I need to fix. Or if your air quality is not great, using HEPA filtration and trying to aim for at least 6 air changes an hour. This is a nice graphic from Zero COVID Thailand. It just shows you dangerous levels of CO2. Really less than 700 is ideal. I went through every room in every clinic that I work at and tested it. And then we, learned that the CO2 levels were hovering around 900 to 1,000 in most places. And so what we did is we put HEPA filters in every single room and in the general waiting areas in the clinic. So your first step is to measure your room. And remember, your room is a 3-dimensional space. So you have to measure the height. So the square footage, just multiply by the ceiling height. And then do some simple calculations. So each exam room in the clinic was about 75 square feet. That corresponds to this size filter, which has a clean air delivery rate of 50. And we calculated 5 air changes an hour plus probably 1 air change an hour from the not great ventilation in that room. So that's one way you can do it. The other thing, it's obviously the engineers will object because this is oversimplified, and I agree. Like if you pack a room with 6-7 people, simply having one little filter will not cut it. So really, it's a much more complex situation involving, what's the viral load of the people there, how many people are in a room, how much fresh air per person, really. But this is a much more simplified way if you can try to get that past clinic management and in facilities that you're working at. But this is Joey Fox is a great account to follow if you're looking for really engineering guidance on upgrading your ventilation, by the way. So this is the steps we took at the clinic. So some of the staff, most of the staff will wear fitted N95 masks, which we got through, from the provincial stockpile free, which is available to most clinics. We used Corsi Rosenthal boxes, which have a clean air delivery rate of about 600 cubic feet per minute. These are for the office areas and the waiting areas, right next to where patients are waiting. And then in each office is a small Honeywell, which is about 50 cubic feet per minute. And these are all run at the highest setting. So just calculating from the clinic, it's a 1,500 square foot clinic, about 12,000 cubic feet. Combining all of the clean air delivery rates, we calculate that it's about 7 air changes an hour in the entire clinic, plus maybe 1 from the ventilation system, maybe a few more from opening doors when we can. And overall, it's a much, much safer environment. A super spreader, unmasked super spreader can get in, but the air will be scrubbed hopefully quickly when they come through. Other patients and staff are protected, but again, not ideal. The ideal would be if everyone wears a mask in that setting. So conclusion, cleaner, fresher air will help beat COVID-19 and future threats. And then speaking of future threats, I've had more than one situation in the last couple of weeks where I'm asked to rule out monkeypox. This is happening more and more. Some of my, I haven't seen a real case myself, but I've sent off labs to the national, swabs to the national lab. We are wearing full airborne precautions for all of these in the hospital. And many clinics are not set up to do that. You see a new vesicular rash now, you should suspect monkeypox because disseminated varicella is very rare now, like the chickenpox, now that most people are vaccinated or had it in childhood. So the Ontario Public Health, to its credit, has recognized the potential for airborne transmission, even though most cases so far have come from close, intimate contact. So colleagues who have seen monkeypox in person have taken throat swabs, have shown that there is a very high viral count in the throat with monkeypox. So the airborne spread threat is there. So upgrading your ventilation, getting all clinics to upgrade ventilation will help prevent the spread of monkeypox as well. And I guess the question is, I get this a lot, is why should we care? Like everyone got Omicron, it seems. Severity is less, hospitals weren't overwhelmed. But the issue is, a lot of people are pointing to South Africa's BA4 and 5 wave. But, we have to remember, South Africa had one of the highest numbers of excess deaths in the entire pandemic. And we have, amongst the Western world, we're not amazing, but we did much better than our closest allies, and definitely not as well as some countries against East Asia. So when you're comparing, mortality and morbidity, you have to realize that almost every susceptible person in South Africa has probably either died or is immune by now. So we have to be careful when we make these comparisons. There are still a lot of lives to save. Now, and the other threat is long-term COVID or long COVID. It's definitely a real threat. We see it more and more in the clinical setting. We see patients coming into the emergency rooms with unexplainable symptoms following an infection with COVID-19. And there are no treatments for this. These clinics are barely getting off the ground right now. And this is not something that anyone would want to wish on anybody right now. And it occurs even in vaccination, even though the incidence is reduced with vaccination. And then there's a lot more studies coming out. There's one recent statistics collection from the UK. Being female is a huge risk factor from some studies, 2 to 3 times more risk if you're a woman, if you're middle-aged, a bunch of other risk factors, especially working in health. So these are, this is something definitely to be worried about. And I find in the discourse that it's often ignored, it's dismissed, but it truly is a real problem that you need to factor in when you're dealing with this disease. Obviously, this is part and parcel of a collection of measures that you need to implement during a surge of wave. It looks like we're starting a new wave now. We just came off of one and had maybe a break, but this is the message we need to get across to the public and to our leaders, that we're going to be on this roller coaster until real measures are done to limit as much as possible the spread of COVID-19. A neat project that we're working on with Masks for Canada is an app to track ventilation. So, with the cooperation of Mapbox, which is a mapping company from Facebook, and also a donation from Barry Hunt at Prescient X, we have about 12 volunteers who are going to read CO2 levels across Ontario, reported on this app. We're going to hopefully create a community of reporters to tell people where the freshest air they can go, where you can go indoors, wearing a good quality mask and not have to worry too much. So in public areas, museums, shopping malls, things like that. So hopefully that will, make getting through the winter a lot easier for Canadians who have to be indoors a lot in the winter. But we'll keep the public posted. Thank you very much for the opportunity to present today.
Thank you so much, Dr. Pirzada. And I just put the link to Masks for Canada in the chat box. And I also put another link to a video that's actually on the coalition website where Dr. Pirzada introduces and hosts Dr. Anthony Leonardi. So that's well worth watching. It's called The T Cells Are Not All Right. So with, our immunity being affected with the onslaught of the variants of concern, it really challenges this whole notion of herd immunity. Leave the questions to the end, as Anne-Marie suggested, and also there's a Q&A place to put the questions to. It'll make moderating easier. So over to you, Anne-Marie. Thanks, Dr. Pirzada.
Yes, thank you so much, Dr. Pirzada. I would like to introduce our next speaker, who will be covering the third portion of our presentation, the What Introduction to Respiratory Protection Programs. And I would like to introduce Mr. Paul Bozek. Paul is an associate professor at the University of Toronto's Dalla School of Public Health, where he is the program director of the master's degree program in occupational hygiene. He's also the chair of the Canadian Registration Board of Occupational Hygienists ROH Examination Committee and is a past president of our association here at OHAO. During the early part of the COVID-19 pandemic, Paul was researching the effectiveness of both N95s and many other masks for bioaerosol exposure control with a grant from the Ontario government. During the original 2003 SARS-1 outbreak, Paul was fit testing healthcare workers in the Greater Toronto area with N95s. So without further ado, I'd love to introduce Paul Bozek.
Thanks, Anne-Marie. Let me just start sharing. And get this into presentation mode. Okay, thank you very much, Anne-Marie, and to the Aerosol Transmission Coalition to have us present on the respiratory protection programs. And this is, I was asked to do an introductory level presentation, so don't expect too much if you're very deep into and already have respiratory protection programs. But for those of you who may be a little bit unfamiliar or who are thinking about what to do in the future with this, perhaps this is a good primer and a place to start. To get some more information to understand what we should be doing for a full-blown program, not just handing out respirators, for example. So the first thing I want to address very briefly is, do I really need a respiratory protection program? And what am I saying, program? I'm trying to emphasize that because, of course, we're talking about the kinds of things you do and potentially even documenting it if you want to be fully compliant with the things that we do to correctly select, care, and use respirators. And by respirators, again, I'm going to emphasize the fact that we are talking about, things like N95s or better, since we know N95s are frankly the lowest level of respiratory protection we can provide generally, but they protect the wearer. We're not talking about programs for source control masking to protect others. So we're thinking about, do we need to worry about those that we are providing N95s or better if we're talking about other types of exposures, not necessarily just COVID-19 and SARS-CoV-2? And do we need to have a program? Well, of course, those of you who are familiar with the Health and Safety Acts in every one of the provinces and federally, that if you're handing out respirators because they're required by the employer to protect an employee from things like either chemical exposures or bioaerosols, etc., then of course you are required to have a program. That's your due diligence. That's how you're going to show an inspector that you are doing everything possible along the way in your design of your program to actually make sure that the worker is protected from those exposures. And certainly, even in areas where respirators might be optional, perhaps because airborne exposures are quote unquote high, or if we're thinking about, again, with bioaerosols like SARS-CoV-2, are we thinking that our employees are asking, or our employer, we think we should be providing an N95, then perhaps we should also be at least considering adopting parts or an entire respiratory protection program to make sure that we are doing everything we can do to protect the worker, in addition to things like Kashif was talking about, into ventilation or isolation or distancing, cohorting, etc. And of course, even from a general point of view, you can imagine that if you want to assure your stakeholders of a robust level of protection, it's like, we're handing out, we're spending money on these N95s now because we're not in the healthcare system, for example. Do we want to make sure that our employees or our visitors or our customers, feel safe, feel like we're doing all that we can do? Then, of course, you want to at least look at and adopt as much as you can from a respiratory protection program point of view. And again, that if you're doing it completely full blown according to the perfect standard to do it, and which I'll just quote in a second, because that's of course where our general guidance comes from, is standards. Then you're going to want to document that you're doing it so that you can, again, show people the evidence about, here's our program, this is how we do things, this is how we select, this is how we care for, this is our disposal method, for instance, for the filtering face pieces, and all the other things that you would go into a life cycle approach to making sure that respirators are handled properly. So the program elements, and again, I'm quoting directly from the standard that everybody in Canada uses, the CSA Z94.4. I just happen to be quoting the 2018 edition, has these bullet points listed, and I'll go through each of these very briefly, just again to give you an introduction or a reminder for some of you about what a full-blown program looks like. Of course, we're going to have roles and responsibilities. We're going to assign people to do things. We should be doing a hazard assessment to do it properly, of course, to understand what we need to actually protect people from, or the degree of protection that's required. We're going to document our respirator selection process so that we understand that, we have selected properly in accordance with either guidelines or appropriately to provide protection to the hazard that we've identified. And of course, in a workplace, training, we want to make sure that everybody understands what they'll be doing. The big thing that, of course, everybody's heard about, especially in the last 2 years, is about respirator fit testing, understanding when a respirator is actually tight fitting. And again, there's a lot of that. I'll just introduce the topic. That will be covered in Mask Smart 3 in more detail a week from now. We'll talk a little bit about use. And then, of course, we should be thinking about, especially for the non-disposable respirators, the cleaning, inspection, maintenance, proper storage so that you don't contaminate them, or that you do decontaminate them after use, for example. That, of course, should be documented where possible, or have a procedure in place. If you're doing a full-blown program, of course, you might need some health surveillance, and I'll briefly get into that. And then, of course, being a program, typically we want to be able to document that we've evaluated our program and we've got records to show that it's working according to plan. So for the roles and responsibilities, of course, typically a single individual is assigned as a program administrator to make sure that everybody understands what they're doing, and they're assigned tasks. And this program administrator, of course, would be collecting records if you're generating them in a full-blown program. Of course, there's going to be responsibilities for users to understand when they have to use a respirator, how to use a respirator, and get trained. But even in a workplace, of course, we want to make sure that supervisors understand, who, where, when respirators have to be used, and who's assigned to doing things like monitoring for proper disposal or storage, etc. Of course, one of the big things in a full-blown program where you are doing fit testing is, what is the responsibility of the fit tester? What are they assigned to do? Are they trained properly? And again, eventually, are they collecting the records that we want them to collect so that we know that everyone who's gone through fit testing has been shown to have a good respirator that fits them well. There might be maintenance, again, if you're using the non-disposable respirators, the half-face piece or higher levels of protection, and that may or may not be assigned to the users or might be individuals specifically. And of course, as I mentioned, health surveillance might be an issue that comes up with your particular workforce. So a healthcare professional might be needed, at least for parts of the evaluation. So for the hazard assessment, myself as a hygienist, this is the part I love. And of course, it doesn't always have to be done by a hygienist in a simple situation. But obviously, if you're dealing with chemical issues or if you're dealing with other types of hazards that you need to worry about in a workplace, it's probably better if you get somebody who has knowledge of occupational hygiene, or at least a competent person who understands what the hazards are. In the standard, of course, they talk about oxygen deficiency. This may or may not be applicable to obviously an industrial type of workplace. That obviously is going to limit the types of respirators that you use. And the concept of immediately dangerous to life and health comes up in the selection, in the hazard assessment process, because of course, if you're talking about a chemical hazard, we need to know, is it dangerous chronically or acutely? And if it's immediately dangerous, then there's certain levels, of course, which will impact our selection. But even for the filtering face piece respirators, like the N95s, we have to assess in our hazard assessment, is there an oil present? And obviously this is more of a concern for an industrial workplace. But if there's an oil present in the air, that can affect what, of course, type of respirator you need to use, because your N95, the N, of course, means it is not resistant to oil. And therefore, if there is an oily mist present in the air and you're handing out N95s to protect people from SARS-CoV-2, it's not going to perform necessarily as well as you think, or it'll get clogged up quickly and they'll have difficulty breathing. So that's when you might have to go to the R or the P designations in a different respirator selection. And of course, what are the agents that we're trying to protect against? Is it SARS-CoV-2? Is it other airborne agents? What are the staff doing, or what are the potential for aerosols to be generated that contain these biological agents? Because of course, an N95 isn't necessarily good enough if you were in a very high risk hospital scenario, but of course it might be perfectly fine if you're just doing dental work without power tools, for instance, and you have somebody who may be potentially contaminated with a bioaerosol being released. And of course, we need to understand what species are present as well, so that we can understand the level or degree of hazard to some extent, even semi-quantitatively, if you're looking at the CSA standard, to identify the proper respirator to be chosen. And of course, for the chemical agents, the kinds of things I'm used to doing when we're not dealing with a pandemic, we need to know what phases are present. Are there gases, or are there vapors, or are there liquid mists around? That will help us select the proper type of respirator. And if we understand what those chemical agents are, then we need to quantify them potentially to compare to an exposure limit to understand the degree of protection provided, to see if the respirator we're using is good enough to reduce the exposure sufficiently. So all those things need to happen in the hazard assessment. In the actual respiratory selection, again, I'm not going to go through that in any detail because that's part of our seminar next week. But of course, you need to tie the hazard assessment to find the right level and right type of respiratory protection required. And once you've decided on the right kind of respirator, of course, you're going to have to screen your users for potential medical limitations. And you might require a medical assessment before selection or use. You can imagine somebody with COPD, or who is somebody who's potentially severely asthmatic. They might not be able to use the kind of respirator that you're providing or suggesting be used, and you might have to go to something else or an alternate solution. And of course, there are many types available, which I'm not going to talk about, just mentioning the fact that, of course, there are air supplying type respirators, the air purifying that we're used to, including the N95s that we've been seeing a lot during the pandemic. And there are other types that are either loose fitting or tight fitting to the face, which may or may not require fit testing, depending on if they're powered and loose fitting and supplying air, for instance, to protect the individual, as opposed to requiring a tight fitting N95. So stay tuned for more details on that, obviously, in next week's webinar. So for training, of course, there's some basic things you can imagine are required for all the users and for other people, but I'm just mentioning a few items here. Obviously, users need to know how to don and doff their respirators correctly. You can imagine, and I've seen it certainly when you watch some of the newscasts, people who are potentially contaminating their hands and then not necessarily sanitizing right away, or contaminating the inside of their masks or their respirators. And that's the kind of thing we want to avoid with proper training, especially if people were using respirators, which you would be with some of the things other than disposable face pieces. We need to have users understand how to do their daily seal checks to make sure that they're fitting tightly. And so there's, again, I'm sure that will be covered somewhat next week. If there are issues with reusable ones or with just getting a supply of respirators that is adequate, we want to make sure that they inspect them, that they have to clean or maintain them and properly store them. And of course, how to identify problems. Your users have to know, for instance, when to change out cartridges if you're using a cartridge type filtering face piece, cartridge type respirator, half face piece, full face piece respirator, or other components like valves, etc. If you're using something other than the filtering face piece, for example. For fit testing, again, this is going to be a topic for next week's seminar, but again, just an introduction to the topic. The CSA standard suggests that, of course, people can do quantitative or qualitative fit testing, but it depends on the type of respirator that is required. And obviously, you don't need to fit test the loose fitting respirators, things like the powered air purifying respirators that you might see some high-risk healthcare workers use. But of course, the fit testing itself, if it's quantitative especially, and certainly even if it's qualitative, gives us a minimum level of assurance that the assigned protection factor or the degree of protection provided by the respirator by the fit is actually achieved for a tight fitting respirator. But that's not the only thing it does. Of course, there are user comfort issues that are also explored when you're doing a proper respiratory fit testing program, just to make sure that if this is a great tight fitting respirator, but of course the user is dying to take it off their face, well, how likely are they really to use it in the long run if you expect them to use it 8 hours a day, for instance, at a shift? So those are the other kinds of things that proper respirator fit testing we'll discuss. And again, I'm sure there's going to be a little bit more of this discussed next week. For cleaning, inspection, maintenance, and storage, again, for the reusable respirators, either people who are using them or maintenance people have to understand how to clean them properly to make sure that they are still in good shape when they reuse them, how to store them to avoid contamination. And of course, when you're talking about more complicated air supplying systems where you have cylinders and hoses for high levels of chemical protection, for instance, there are other specialized testing that has to occur. And that so therefore people who are assigned these tasks understand how to do it. That's the kind of thing, again, should be documented in your program. And again, just briefly touching about health surveillance that should be occurring. There is in the CSA standard, and typically for a proper program, both a non-medical surveillance system where there's at least a screening that you give all your users for physical or psychological issues that might prevent them or limit their use, right? You can imagine people who are claustrophobic, you want them to self-identify in a non-medical surveillance program before you start handing out respirators. And of course, if there are any other triggers, private medical information that you can't share with your screeners, that's when you would, but things that might be of concern for respiratory protection use, that's when you need to go to medical surveillance that gets kicked up a notch to either an health nurse or an occupational physician to make sure that you can provide the proper accommodation or potentially even exclusion from doing things like fit testing or even using a respirator at all. And of course, to sum up these kinds of things, if you are doing a full-blown respiratory protection program, you want to evaluate, is everything actually working properly? You might be doing informal or proper formal external audits once in a while, looking at your documentation, your program, talking to people to make sure that the program is working properly and that the respirators are actually being used the way they're supposed to be done. Again, this could involve just records. It could be examining if the end users are comfortable with the program and understood the training. And of course, the idea is to identify any corrective actions to improve what you're doing to make sure that you can provide assurance that the respirators are used properly and selected properly in your workplace. And finally, record keeping for a program. Again, you want to keep as many records as you feel is appropriate. There are some suggested items listed here that are straight out of the standard so that you have documentation for how you're doing these things, for who's doing them, that you have records of the assessments so that you know you're providing respirators that are appropriate for the type of hazards that are present, that you have medical records collected by someone, separately outside of your organization where applicable, or certainly the screening health surveillance records collected internally. You've got records of training and where needed, inspection or maintenance reports. And again, those program evaluation results so that you can continue to progress and improve your program if there's any problems with it. So with that, I think I will stop, and hopefully people have had an introduction that they find useful, and we will hear more about some of those details, as I mentioned, in MSMART 3 next week.
Thanks so much, Paul. Really grateful for you sharing your knowledge and your time with us all. And Paul also features in our coalition meetings as well. So, like I said, we're not exclusive. We're inclusive. So you might want to just put your email in the chat box if you actually want to participate. So the next speaker. And just before I go on to Neil, the next present, I put a link in the chat box to the registration for the 22nd of June. And, Lydia Renton's kindly offered to present along with Dr. Simon Smith, who actually had a great deal to do with the Canadian standard, the control banning bioaerosol selection piece. And he's also spearheaded the new standard, 94.4.1. which is specification. So now I just want to introduce you to Neil McDermott. Neil McDermott is an occupational hygienist and specialist in health and safety. He's a consultant with the Public Health and Safety Association, or PSHSA is the acronym in Ontario. He has over 22 years experience in health and safety, as well as leadership, management, and culture. He has worked extensively supporting clients around implementing respiratory protection programs in terms of education. He has an applied master's in science degree in occupational health sciences through McGill University. So Neil has many years experience doing this training and providing, helping implement programs. So over to you, Neil. Thanks very much.
Okay, thank you, Kevin, for that introduction. Yeah, so my name is Neil McDermott. I work for Public Services Health and Safety Association. I've been asked to speak to you about lessons learned through those years of experience that we have gained through developing programs, but also delivering services related to this. So after the first SARS event in the province, after 2004, we were tasked with developing these services to support the healthcare sector. I tried to structure my presentation around the 10 core elements that Paul just went through with you. There's a lot of content there. I'm going to move through them quickly. I kind of use some of these slides to sort of help frame the conversation, but I'm going to talk mainly about those lessons learned. So yeah, just for who we are, we're a designated entity. We're the public services. I'm part of the healthcare team. We do a lot of training and resources. One of the things that I realize that clients don't appreciate is that we provide a lot of services for free and a lot of support. And a lot of clients and employers really don't take advantage of that to the extent that they could. I'm not trying to sell anybody here. I just want people to appreciate sort of the background in terms of what we're doing. We're doing a lot of qualitative fit testing. We used to do more quantitative, but we haven't really been maintaining the quantitative port account machines. We do fit testing service, but we prefer to do the train the fit tester course. Many clients think that we're saying train the trainer, so we don't teach you how to train. We give you good content that you could use, but the focus is on building capacity within the organization so they don't have to keep coming back. And we do that at a very low price. We created a virtual one during the pandemic, and there's a sort of 3 parts to it: an e-learning, a practical, and an evaluation. We also get requests for specific customization and development around the programs. And for most clients, we just give them a sample. And we tend to focus more on the particulate respiratory protection, just because in the healthcare that tends to be more the focus. So some of the things we said, I don't want to appear like I'm contradicting, because I'm not, but we traditionally have said respirators are our last line of defense. And the reason we say that is because we want people to focus on going upstream at the source, engineering solutions. If you can eliminate, you can substitute, great, but engineering solutions are sort of preferred because they tend to be more effective if they're properly maintained, right? Respirators got to be sized right, they got to be fit tested, right? That people got to wear them properly. People sometimes go past the usage dates of different things. So there's a lot of variables, and so we know that this is something that may be required, and we see in the pandemic it is, and with biologicals it's more likely than not to be required. But the legislation is definitely written in such a way that they're putting the emphasis on engineering solutions and moving up the hierarchy and working your way down. And here I'm just giving you sort of reasons when a respirator could be used, but no doubt people drew attention to the fact that with SARS-CoV-2, the necessity of using it. And you can see how when people are in close proximity to one another and dealing with patients and others who are moving around, this is going to be essential. Second big lesson is that you really do need senior management commitment and the resources that flow from that. A lot of times, my clients don't even understand what a respiratory protection program is. So Paul went through and helped, give us that level of awareness. They don't realize that it needs to be written. One of the things that happened during the pandemic is that they updated Regulation 833. This is the one for control of exposure to biological and chemical agents. So that happened right at the beginning of the pandemic. Lots of changes and amendments were made. There is a specific section, legal requirements around respiratory protection programs. CSA Z94.4 2018. That is the best practice standard in Canada, and that's the one that we align our programs to. But it is the law, and it is the minimum requirements have to be met. We want to make sure that the roles and responsibilities are super clear. When we don't make this a priority, we find that there tends to be an increase in trends in communicable diseases. So this is the stuff that Paul went through. I would just add that sometimes clients don't appreciate that, that you have to do, steps 1 through 6 before you actually start to use the respirator, right? And some of this stuff, there's ways to do this to become more efficient or more effective at doing that. And I can sort of highlight some of those sort of key things, but all steps are going to be critical. I find clients often, they don't always appreciate the necessity for a comprehensive program, let alone understand that there's a need for one with respiratory protection. The third lesson is around exposure assessment. These are sort of basic to the proper use of respiratory protection equipment. Paul sort of, he communicated it as a passion, right? He's as a hygienist, he was saying, oh, I like this part, right? That's because he's a hygienist, and this is right up his alley and his skill set, and he likes to get into the science of it and stuff. So, he's got a downplaying saying it could be anybody, but definitely industrial hygienists are well positioned to do this. And we look for qualified people, and that tends to be certified occupational hygienist, registered occupational hygienist. If it's with infectious diseases, we often bring in IPAC people, but definitely, we want to understand what the role of an exposure assessment can be. So this is, the process of estimating or measuring the magnitude, frequency, and duration of exposure to an agent, along with the number and the characteristic of the population exposed. So that's sort of one definition. So many clients do not have an understanding and competency to assess the concentration. We need this information from these assessments to establish the required change-out schedules for chemical cartridges and gas masks used for gases and vapors. And again, I would say that we deal with clients who are wearing, particular respirators, and there's a, gas or vapor phase, and they don't realize that they didn't select the right respirator. They didn't understand the science of that, the necessity of selecting a respirator with the appropriate cartridges for vapor. And I would add that, the CSA standard has a control banding approach with an algorithm in there. So one of the hazard risk assessments is identifying the need and the level of protection required for exposures. So the control banding approach is also sort of a helpful way to do that, especially when you don't have the depth that someone like Paul would have in this area, or Anne-Marie or myself or Kevin. Lesson 4, the selection of proper respirators should be performed by a qualified person. I already kind of spoke to that. I do want to say though, having that education and training and experience is really important. And when they help you set this up, that you have an internal document, a script to sort of follow, right? And through my experiences, what I see is we see occ health nurses and IPAC specialists and even occupational physicians and others getting into this, and brilliant people, smart people, but if they don't have the full background, they haven't really made this a specialty and focused on it, sometimes they don't appreciate all the different things that are required. I can think about, during the Ebola phase, seeing some of these standards being, deviating, telling people you don't need to shave, right? Or telling people, never touch the outside of a mask. And of course, we need to do that for seal check, or, put your hands like this. There's a lot of things that they're saying that are sort of contradictory. And so, bringing the qualified people in, and this may be a group of people with various skill sets. There was also a lot of, during the pandemic, we experienced a lot of people who were concerned about the quality of the respirators they were using. There's a lot of counterfeit products. So we were able to help navigate through that. And again, I think hygienists were sort of better equipped to do that. I'm not going to go through and explain in detail the differences between the different, but I just kind of want to start with, helping people understand there are different types of respirators, and they do come with limitations. Right? So you have to understand those limitations. And I think Paul did speak to some of those, right? So you got an immediately dangerous to life and health atmosphere. Are you exceeding the maximum use concentration of your respirator? Is it an oxygen deficient environment? Right? So these are all major considerations that if you get it wrong, you can definitely have that. And so that level of knowledge people don't have, and so it is important to sort of bring in the right people. The air purifying ones, right? We call them respirators, not masks. I mean, that's sort of, we try to establish that language with clients because we want to differentiate between surgical masks, procedural masks. They're tight fitting. They're required to be sealed, fit tested, and so not everybody appreciates that, right? They're not always understanding that you can't just put it on and off you go. They're actually not. The whole program thing is not as straightforward, simple as straightforward as people just perceive. And there's sort of this misconception among, I guess, the common population that's the case. And and just so I'm not going to go through and explain the different types, but definitely your program's going to have to be adjusted if you're using the elastomeric type. Requires a higher degree of care and maintenance for that equipment. There's also a misunderstanding around when they see N95 or R95, they misunderstand the level of protection, right? So there is an issue around the seal, and various documents with a 10% leakage or whatever is assumed with the validation of these qualitative methods. But this MPPS is the minimum particle size, right? Penetration or particle penetration size. So what we're getting at here is that they test the respirators, like NIOSH has a method that they test, and they do it at the most difficult capture range, which is this sort of like 0.1 to 0.3 or 0.4, depending on which reference you're looking at. But we're looking at respiratory secretions and that have these viruses associated with them. So the particle size is actually much larger and the level of protection is actually a lot higher. So if I kind of just quickly annotate, you see, if the particle was a 1 micron, right, and you draw that back over, you're seeing that the level of protection is way higher than the 95%. That assumes that you've got a good fit, right, and that they're being worn and used properly, which often that's not the case. We also heard about the duty to accommodate to the point of undue hardship. So a lot of clients don't appreciate that. So if it's a $2,000 PAPR that is needed, that is reasonable. It's expensive, but it's not going to break you. And the interpretation of the law compels employers to do this. And we see this for accommodating people around religious reasons, around shaving their beards, or some hair coverings or head coverings. And sometimes we don't get the concentration and right, and even with biologicals, we don't select the right respirators. So this is probably an option that in some instances should be being used when the risk warrants it in the healthcare sector. Some people don't get it, that there's a major difference between surgical masks and procedural masks and respirators. And I think there's a lot of confusion around the degree of effectiveness. It's well established, the effectiveness of these. There's obviously limitations and certain assumptions. Same with ventilation. But I think people came in and created a lot of sort of confusion around that. So we have to educate people and around this and help them understand the purpose of them and what they're used for and the differences. And so I guess this brings us to the fifth lesson learned. Health assessments must be completed. So this is necessary to identify medical conditions that may place an employee required to be used. I'm not going to read you this because Paul did this already, but we as part of our materials and things that we provide clients and things that we can share with clients is these disposable health screening forms. So for a pre-screening process where you ask certain questions, you don't tell us if you have a particular health condition, but if you do, we're going to send you off to a health professional who will assess you. So you might have 100 people in an organization, and 5 of them need to go off to the doctors, their family physician or some specialist, someone that's qualified. And we give you the forms and the paperwork to sort of help make that easier. Number 6, tight-fitting respirators need to be sized correctly and fit tested. Yeah, let me, 1 second here, grab my notes. Yeah, so it's helping clients understand that tight-fitted respirators need to be sized correctly and fitted. You can't, a respirator is not going to protect you if it doesn't have a proper fit to your face, right? And it requires a fit test to be done to seal between the respirator's face piece and the user. And of course, this is to ensure that no leakage of contaminated air into the face piece. And I actually have a number of things here. So through my years of experience of doing fit testing with people, sometimes fit testing isn't completed. Sometimes it's expired. Fit testers are completed without, the person who's doing the fit testing doesn't have the training or the experience. They leave out or don't update their comfort assessment. So there's this new, more strict requirement that they failed to implement around movements, observations. There's a 5-minute waiting period, the scoring, and the final comfort question. So there was a major sort of piece that was added in the 2018 CSA standard that people failed to realize. Sometimes employers will stand around and hover and put pressure on them, and so they're trying to get them to say that it passes. And yeah, one size fit all sounds nice, but you need a range for the different sizes, and you get a lot of leakages around the nose, the chin, and around the chin and the dimples in the cheek. And yeah, so that's one of the considerations. I show here, I guess next week we're going to get into more details. I actually had a lot more I could share there, but I just, for the sake of time. But here just shows you, like, during the pandemic, there was on the TV, Local 2 in the States was showing a health clinic doing fit testing, and they had kind of picked this up to sort of increase the capacity in the system. But you can see how, with that lack of experience and knowledge, that there's actually supposed to be, this is actually supposed to be in a hole that's closer to the mouth. And sometimes they spray it right into the mouth, and they should be doing it into the corners. Sometimes this is nice, somewhat level, but sometimes they've got it on a slant, and so the valves can be clogged. So there's all sorts of issues that people don't appreciate that sort of make the results invalid, and they get sort of a false negative result. Okay, clear. So lesson 7, employers are responsible to ensure that the workers know how to use their respirators. So we talk about being able to on and off them effectively, be able to do the seal check, and understand that there are various interferences. So we show this slide, and it's really to show how, sometimes people don't even, they don't get the straps right. They put them in the wrong order. They don't clean their hands. They don't wait the 20 seconds. So they're putting contaminated hands to their face. They slide their fingers and hands into their eyes. They put their straps too close on the ears. They're doing a seal check, up in their eyes. They leave a gap when they're doing it. So there's a lot of things that can kind of go wrong when they're doffing it. They do it too quickly, and it potentially flips down and self-contaminates, especially if you get the strap order incorrect. Sometimes they stretch the straps, and they sit not as tight on the face. So these are just a sort of a handful of things that can present themselves. They struggle with the 3-panel type respirators that were shown earlier on the screen. So we'll demonstrate and show them how to do that, so it's much easier for them. Lesson 8, respirators must be properly cared for so that they remain in good condition. And Paul will go through and sort of highlight some of the key things that are in the program. So I find that employers often don't put in place adequate measures and instructions to ensure that they're being adequately cared for. And one particular issue that had come up was, and this was about sick kids when I was with Anne-Marie there, and and there was soap in the valve. They had washed it, they didn't rinse it properly, and then it clogged up the valve. So just little things like that. We've seen over the years where people, they didn't keep a good track of their inventory. They put their inventory in a storage unit. Water got in there. It wasn't sealed properly. It got damaged, expired product, those sorts of things. Lesson 9, training on respirators must be comprehensive and complete. You know, Paul said training. That's not always the case. We see, you know, sometimes people not understanding the necessity, trying to, you know, do things through emails, through, you know, sort of less effective means to do it, or not at all, or incomplete. This also implies that all the different parties that play those various roles and responsibilities in the program, that they have the proper training and education as well. We want this training to be done prior to the use of it. So that's key, and then done at a frequency, obviously, that is going to remain relevant. And yeah, just provide some further information, which I don't really have the time to go through, but it's just sort of a summary of sort of key points. And yeah, we talked about it being role specific, designated to address hazard specific risks, provided by a qualified person, reviewed annually and on an ongoing basis. This brings me to lesson learned number 10. The program must be evaluated, verified compliance, and appropriate records must be kept. So I find in general, you know, people don't evaluate their health and safety programs, let alone the respiratory protection one. It's sort of a, like, just a relief that they got stuff in place, that they don't, you know, take the time. So maybe assigning someone specifically the role to do this and holding them accountable through maybe the performance process could be helpful. The record keeping, Paul stressed, you know, due diligence as sort of a key reason for that. But also, if you want to go back and evaluate your program and see what happened and learn from it, and you know, have that as a historical record, then that's going to be important. So that's it for me. Hopefully, I didn't take too long, but yeah, that's my top 10 lessons learned.
Awesome. Thank you so much, Neil, for sharing your insight and experience. You know, having done program development and respirator fit testing in the past, there are a lot of nuances in this protective field that it's really important for people who want to, if they're considering establishing one, you know, the specific measures that need to be taken. So that wraps up the formal portion of our presentations today, and we hope that our participants have, you know, if you have not previously considered a respiratory protection program, things to consider, and know that there are resources available to help you, and the importance of going to a qualified professional who can help you work through the key aspects of a respiratory protection program. You know, Neil mentioned that he's from a provincial health and safety association here in Ontario. If you're outside of Ontario, we encourage you to look at your provincial occupational health and safety services groups. OHAO has a consultants directory if you're looking for a consultant to do this type of work for you. So with that, we are going to go to our question and answer box, and they will be co-moderated by Kevin and I. So Kevin, how about I'll read out the first one and then we'll just go back and forth. So if actually, Jason, you can put the spotlights of our presenters on, that would be great.
Yeah, everybody needs to turn their camera on, please.
Perfect. Yes, perfect. Okay. So first question, this is for Dr. Pirzada. In your opinion, what is the best way to get the message across to physicians and other healthcare professionals that the pandemic is not over, that airborne transmission should focus on prevention, mitigation, and that masking respirators should be standard practice and expectation in indoor spaces? See so many smart, committed doctors not masking and wonder how to get through.
No, it's been, especially in the last week with the healthcare mandates dropping in clinics, there's a lot of heated discussions. I know, I work with a very diverse group of colleagues. Many of them, they have opinions that match with, people who should know better but don't. I think the best way is to bring it back to the patient. The question you can ask these colleagues is, would you bring your 85-year-old mother to a clinic without airborne precautions, knowing that even with vaccination, any breakthrough infection is a huge risk to them? Would you bring a newborn child, obviously not able to be vaccinated, into a clinic without airborne precautions? I think, bring it back to that core thing. Everyone has their personal preferences, but in the job, as a doctor, as a healthcare worker, you have to put the needs of your patients first. And preventing airborne transmission in your clinic is the best way to do that right now.
Thank you, Dr. Kashif.
Okay, there's a question. It was actually in the chat earlier on that came up when Kashif was presenting, and Kashif mentioned fitted respirators, but Nancy Henry's asked the staff that are wearing N95s, were they fit tested, Kashif?
No, they weren't. Like, we use the OHAOs, which have sort of a fairly high success rate without being fitted. Community fit testing is not really that available. Like, we'd have to set up our own program, which, eventually I think we'll have to, but it would be nice if the Ministry of Health or the local hospital offered this thing to clinics to allow the staff to be properly fit tested. Because right now it's we're just hoping that the OHAO, which is the model that we use, fits as much as possible.
I know some suppliers, when I was in Australia, for example, when I was working at a mine site, 3M would actually come out to the mine site and do fit testing for the workers as part of the service. It might be worth reaching out to the suppliers like 3M perhaps might offer to do something like that.
Yeah, maybe you guys missed it, but like we'll come out, we'll train your staff for $150. You buy the kit and the respirators, and you're off to running. Like, you can do this yourself for $150. It's really cost feasible, and we have tons of courses available online for them. So there's really, I don't want to leave people the impression that this is difficult to get the fit testing, because we're sitting here ready to do it for you, and so are all the other different consulting companies out there.
Maybe it's something I could reach out and we could try to publicize it to other physicians too and their clinics.
That'd be wonderful. Thanks, Neil, and thanks, Kashif. I just wanted to make and Anne-Marie, there was also a question that I just wanted to refer to. Somebody from the US was asking about advocacy. Greetings from the US. Are there US-based advocacy groups like the Canadian Aerosol Transmission Coalition or OHAO, where I can get help to convince my workplace to put in mitigations, allow the use of better respirators, including elastomerics? My workplace forbids elastomerics, but I get a much better fit with those. I'm looking for help to get them to adopt mitigations. Corsi Rosenthal box, CO2 PM, the carbon dioxide measurements and policies allow better masks because one-way masking less effective. And I just put in the chat box, we do have a person that attends our meetings, the coalition meetings, Ken Martinez, and he represents IBEC, and he also presented through OHAO. As far as a US connection to get more information, he's probably a good contact. So we could sort of introduce you to him. And also, I guess the AIHA, through Larry Sloan is another group as well. And they do quite a bit of advocacy work as well. I don't know if anybody else had anything to add to that about the US. No? Okay, so that's for you, Frank.
Thanks for putting that in the chat.
Okay, back to you, Anne-Marie.
On to the next question. I think perhaps this would be a good question for one of the hygienists. Paul, with mask mandates being dropped everywhere in, different, well, public health, airlines, public transit, etc. How do I advocate? The question is, how do I advocate in my workplace for a hazard, for example, in this case, respiratory hazard, to be studied, and the appropriate respirators provide at least as an option for workers who want them? So
Well, in a Canadian jurisdiction, I'm sure, yeah, I mean, if you have an active joint health and safety committee, that's one place to start advocating. And certainly if you're in a place that has organized labor, i.e. you're unionized, I'm sure that there are union resources to help as well. In other settings in the private sector, I can imagine that's difficult if there is resistance. And it's a matter of education to some extent. And I know that, certainly I've heard through various contacts that, because we're hearing provincially here in the province of Ontario, for example, the chief medical officer of health says it's safe. Right, so we don't have to wear masks, but on the same breath, he's saying, but it's highly recommended that you still wear masks at work, etc., in various locations. So you got to read those with a grain of salt, and I think also start looking for other types of resources that you might be able to share. Neil, do you have any general resources that you're referring people to these days to try and get the employers to be convinced?
We recently, so OHAO and myself, like PHSA, did a session for ONA, and the real theme or part of that presentation was around knowledge activism, and so that's an excellent. I don't know if Kevin can share that document, but it's a real good document because it kind of gives a framework for workers, and we really believe that a lot of the social change that's going to happen these days is going to come from workers sort of organizing and doing that effectively. So I think that's an excellent sort of framework and way to approach it because there's such a range of employers and some of them are already got it and understand it, and then others are just, it's hard to even, they don't share the same values and have different belief systems.
And just on that, so each of us presented, it was kind of how do we convince our employers that we need to have respirators and a respiratory protection program. And the last presenter was John Odek, and he really provided sort of a good strategy for around advocacy, like what workers can do to really rattle the cage. And that's probably I'm not sure whether ONA actually will provide that and make that available, but if anybody wants to get that material, we can share that. It might be worthwhile looking at it as well. Okay, so there's an interesting question here from Wagish, Yajaman. Great question, Wagish. Curious to know from both medical and hygiene community in the process of fit testing, has anyone come across situations where the person's ability to smell and taste are affected due to COVID? As not everyone who has had COVID gets their sense of smell and taste back, according to some long-term studies. So I guess where he's going with that is, qualitative fit testing, and maybe sodium saccharin's one of the things that you do qualitative fit testing with, and a person's ability to actually sense the sodium saccharin. So that's an interesting question. I don't know if anybody else has come across that.
Yeah, and I can jump in. So first of all, the qualitative method is a taste test, not a smell test. But I think Vagish makes the point that both could be impacted, and we do the qualitative, the sensitivity step first. So it helps us get a sense if they can detect it and to what degree. Me personally, I've only recently I had somebody who wasn't able to detect it, but I don't know if it was COVID related. So I don't know if anybody else has any experiences.
I've been doing a lot of quantitative fit testing the last 2 years because we were able to get quantitative fit testing equipment, but I know that's not always possible. So I mean, you would obviously, Neil, if somebody's absolutely cannot taste it, then you'd have to refer them for quantitative fit testing, because you don't really have an alternate unless you can, they're only not able to sense sweet or only not able to sense bitter. So I can imagine that is a percentage of the population, though, and that would be a concern going forward.
Okay, I might hand it back to Anne-Marie. We're kind of mindful of time. It's
we're just
1:28 at the moment, so back to you.
I think we have time for one quick question, and then we will wrap it up, or perhaps not actually that quick, but it's worth discussing. Could the presenters perhaps comment on the relationship between respiratory protection and source control masking, and why they think there's such a gap in the messaging about how these are both different and 100% complementary? Who would like to take?
The messaging is confusing because you think it's the same thing, right? I mean, they're handing out N95s to teachers in the province of Ontario, for instance, in the last year, and say they're not fitted masks. And, so that means that they're only source protection, and they might be providing some level of personal protection, but we don't know. And so therefore, an individual person wearing an N95, even if it's given to them by their employer, doesn't necessarily know. And that's why we want a respiratory protection program for those kinds of places who really think that they're trying to protect the individual, not to protect the others. I think this is, an issue of education again, but I don't have the answer as to, other than, it's very difficult sometimes to make people read the stuff that's out there, but there is a lot of stuff out there that talks about the difference between source control and personal protective equipment. So Neil, if you've got any, insights into the practical things, from an academic point of view, I obviously spend a lot of time looking at the differences, but we don't necessarily get out to implementing those things.
Sure, yeah, and I mean, just to sort of go off of what you were saying, I know the Ministry of Labor, like training, skills and development, they've been enforcing that if you provide a respirator, you have to do the fit testing. So that's their sort of position on it. Maybe it's changed or whatever, but that historically that's been the case. I'm not sure how they're approaching K95s and those types of respirators, but yeah, I mean, I just would add that and then leave it at that.
Okay, well, this draws to an end. It is 1:30, so I would like to thank all of our presenters today for joining us and sharing their time about this very important topic of respiratory protection in the workplace. For those of you who have asked, yes, this presentation has been recorded and it will be posted on OHAO as well as the Canadian Aerosol Transmission Coalition's website. Please join us next Wednesday, June 22nd, for Mask Smart 3, protecting workers from airborne hazards from 12 to 1:30. The link is in the chat, but also look to your email boxes where you'll receive a detailed outline on the session's content, which will be more focused on the practical aspects of selecting, using, and carrying of respirators, as well as the basics of an actual respirator fit test and fit check. Okay, so on behalf of OHAO and the Canadian Aerosol Transmission Coalition, thank you very much.